Пусть она пишет, ничего страшного.
Да.
Please take your place. We have to start.
But thank you. This is grazie. No.
Okay, so now I want to introduce Natальya, the last speaker of today, with her nice case about fracture of both condyle, both sides. In 1990, she was student at the Kalin State Medical Institute in Russia. Then she did a postgraduate course in orthodontics at VieSID State Medical Academy. In 2010, she did a postgraduate course at the Biotechnology and Interdisciplinary Department of Danube University at Krebs. Did a course with Professor Slavice. She got a master's degree, and her master thesis was about estimation of the difference between nocturnal skin of praxis and diurnal parafunctional activity of human. In 2010, she did a course with Professor Sato about orthodontics in craniofacial dysfunction. She has her own private dental center in Bern. Okay, please, Natальya, it's your turn.
So, thank you for the introduce, Daniela. Thank you very much. So, first of all, I want to say that I'm so happy to be here. I'm proud to be here. And I decided to come here because I want to support the Christian at this tough time, first of all. And I want to support the VieSID because I want to see my teachers. It's very important to me. And 2 years of silence and 2 years Zoom live, I think it's too much. So I think you agree. So I decided to bring you a difficult case. Surely difficult case for me, because I can understand maybe somebody can treat this patient more easy way. But I decided to open my kitchen. And I bring my mistakes, I bring my thoughts, I bring my lessons, and finally I bring my conclusions. So, look at this lady, this young lady, 34 years. It was was 2016. Don't estimate this photo because I got this from emergency department. So imagine a very nice, very calm evening, summer, good weather, and this lady was on bicycle traveling. So it was a bicycle accident, and this evening ended by falling down, and she turned over this bicycle. And the main complaints was severe dull pain in both tingy, of course, it's understandable. Open mouth invitation 90 millimeters only, and speech and chewing problem, headache and sleep problem. So it was the first day of my vacation. So and my partner called me and asked me to come back because we have a problem with our surgeon. Imagine, she's my implantologist. So I canceled my vacation and came back to office because it was a very acute situation for us. So in analysis, bicycle accident 1 day before, orthodontic treatment 10 years ago with 4 premolars extraction, like Professor Soto, like it's for you. 2 years before patient complained on the right side, stingy dysfunction. I found this information in the history. And the patient is implantologist, and no specific problem in general health is good news for us, and no allergy. So look at this picture. This picture I got from emergency department. It just put the special wires, emergency wires in the mouth, and you can see the open mouth or open wide. The many traumas, soft tissues, and if you see the panoramic X-ray, X-ray will go also from emergency department. You can see the absence of 2 condyles. But we decided to make the CT because I don't believe there are this kind of X-ray. So we decided to prepare the CT, and we found not only the fracture of both condyles, but also the 2 big problem in the middle of the lower jaw and cracks on the upper jaw near the first incisors, so many cracks in the enamel. So you can see the pieces of the condyles inside the ramus. And according to the American Academy of Head and Neck Surgery Foundation, most common mandibular fracture location, this is a special scheme, and you can see the condyle fracture is 26-29%, so it happens very often. And if we try to estimate the condyle, we have 3 kind of level of fracture. So condyle head, condyle neck, and subcondyle fracture. So you know that I tried to fulfill this our nice scheme, palpation scheme, but you know the pain was everywhere. At that time it was not useful for me because the pain was everywhere, and it was 1 day after the accident, and she took the remedies, so analgesics, so and sedative remedies. So I decided to check and analyze the situation in the mouse, but the first challenge was the impressions. You know, she has a special emergency wires inside the mouse, so it's so difficult to make impressions, and I have no chance to prepare the special models, separate models. So it's difficult to measure in these models, but such is life. So you can see the interesting. Look at this interesting position position of the models in the articulator. It's very near the condyle, you see? And you know, it's very steep anterior guidance. It's huge anterior guidance, close to the mandible. And if you estimate the upper and lower jaw, you can see that we have a narrow upper, so absence of the first premolars, and also lower arch. And more important, I fight with these nice incisors because during the previous orthodontic treatment, they tilt vestibulum. So you can see the contact on the buccal segment, and the contact was only the 1-7 tooth and second 7, and nothing more. It was open wide and no contact near the teeth. So you can estimate the occlusion on the buccal segment, no good contact, on the only contact near the canines and the incisors. And interesting that there is no scale to measure this wonderful posterior occlusal plane. You can see this posterior occlusal plane more than 25 degrees. And the occlusal plane inclination approximately 20, you see. What it means? It's a key point to make decision in treatment. So you can see their anterior guidance 90 and 100. I never seen before, and I never done it before. It's crazy. And you can see the canine, right side 41 and left side 55. It's a very symmetric position of the canines. It also will be make decision in treatment. So I prepared the TEP, and you can see in condyles severe skeletal class 2, strongly brachiofacial, and look at this red color. On the red color, I never see it before. So it's dolichofacial type. You can see 3D dolichofacial type. Very short the ramus of the mandible. And problem list: tooth to mandible maxilla acute trauma, acute pain, dolichofacial skeletal type, 38 and 34 wisdom teeth are not extracted on the lower jaw. Open mouth limitation and extracted premolars during previous orthodontic treatment. Very steep posterior occlusal plane, right and left more than 20 degrees. Steep anterior guidance, narrow up and lower dental arches, and muscles problem. So it's interesting story for me because I'm orthodontist at the previous life. And after the third course, I started to use the functional orthodontic treatment, and now I shifted to the diagnosis and also the difficult, complex treatment, complex cases. And for me, but I'm not surgeon because this is trauma, acute trauma and fracture, both condyle. What can we do? And this is the first questions for my auditorium for you. Please, what we are going to do and what treatment options come to your mind? What do you think about this situation, please? Maybe not an orthodontist, maybe prosthodontist can help me in another opinion, maybe in treatment approach. Can we discuss, please? I think you are tired. It was a long day. So, nice guy.
I think that we can do the sprint. High sprint.
High sprint. Yes, interesting suggestions.
trying to distract it and to give the possible to the muscles to reposition the condyle.
Yes, that's great. I agree. It's interesting idea. So I just discussed with Daniela Starina before starting our lecture. So the suggestion was also the big splint to make distraction, and then to go to arrange occlusal interference. Yeah.
I know from your paper that this is a non-surgical case, so, but I'll play the devil's advocate and ask, they came out of the emergency department with their arch bars on, ready to fixate the upper lower jaw. Was there a surgical plan proposed?
We have discussed with many, not many, 4 surgeons, because we have a limited in time, you know, because this was 1 day after the trauma. So, and we discussed with surgeons, and almost all of them insisted to the surgery, insisted to the surgeon way of thinking. So, first one splint, second one in surgery. So, can you make suggestions? So, Professor Rausch.
I would like, because she has a fracture of the bone, I would like with her little bit rehabilitation this structure first, stable, not immediately splint, because I have no experience, just major. If you immediately do the splint, here it's not stable, and if this structure, this fracture get worse, and this will be a big problem. This I'm thinking, because if you're thinking anybody other place, you have a fracture, other bone, you need the timing to fix there, that rehabilitation is fracture in the position. I still don't know this fracture is already to this position or the fracture on the stay there. I think I would like the case, if I do this, I would like in certain times stay stable, let the bone healing, and let the fracture get a healing, and then I do splint, and then I begin deloading this condyle. Because at the same time, if you do anything, if the fracture gets worse, maybe you got more problem. It's not my thinking.
Okay. Thank you very much. Thank you very much. So, interesting decision. So I think I agree with the Professor Rausch, because it's very important. We have to solve the 2 problems, you know, to heal first of all the tissues, and second one that we can restore the functions and occlusion and so on. So, anybody?
It's a bilateral intercapsular fracture. It's complete deviation and dislocation, so there is compression. You need to heal the muscles first, because they're torn, for sure. They probably have partial rupture, you can see that on the MRI. So you need to heal, but you need a little bit of decompression in this case. And because this is an intercapsular, it's still inside a capsule, it's easy to recapture. But you need to heal, that takes about a month, and in 3 months it should be in its original place. But you need a splint immediately, I think.
I agree to heal, but the problem was the claustrophobia. She cannot to go to the machine, crying, so it was terrible. So we stopped and decided to use the CT, but the main suggestion to heal, yes? Well, to heal first place, okay. Maybe we have a surgeons in the auditorium now? I am lucky, because every time surgeons hate me, and sometimes discuss with me, you hate the surgery. I not hate the surgery. I hate the invasive treatment, interventions. Okay, we are going to have indications for open reduction. All surgeons insisted on open reduction. It was amazing. Each of them decided, okay, no healing, open healing, and then you can put the brace. It's something whatever you want. So you see, and more interesting, the absolute indication for open treatment of condyle fracture in bilateral fractures. So it was very tough questions for me because it was my responsibility and I had to do this. But fortunately, all surgeons insisted on open treatment, but some of them had already heard about the crazy orthodontist after the third course. So, and she come back at my home, at my dental office, and I start to think, okay, I have no chance to avoid being involved in this situation. So, and I remember, like Professor Slavichik always said, switch your brain. So I start to think what I can do for this patient because she's a surgeon. Imagine she understands what's happening. So understand, it's very difficult. So I decided, okay, and I decided to use the approach of Professor Sada, but we will see them more later. So first of all, I want to say about the complication of open treatment. I remember yesterday we had the wonderful presentation of our colleague from Greece. I see the same pictures, and I see, I understand that the situation is similar in different countries. You see, the gold standard, it's open the TMG, and sometimes the patient come back with some kind of fixations plates, carbon, metal, plastic, and so on. But you see the long scale of complications. So it's very invasive treatment, so it's dangerous. And do you remember that my patient has already the dysfunction on the right side previously after the orthodontic treatment? So the condyle was not good form. So, but we have also a conservative treatment, you know. There are two the main ways to solve the fractures. So the open treatment and conservative. But you see the complications after the conservative treatment: chronic pain, greater shortening rounds, and so on. So what's happening? Because we're not developing the TMG, we save the tissues, so but what's happening? So it's the next questions for you, my dear colleagues. So let's assume why complications occur in conservative treatment. What do you think about it? So, what do you think? I tried to find some papers, in literature, so using this approach, and it was interesting. They used only straight wire technique and straight wire thinking, like Professor says, thinking. So I decided to put to the one picture. You see why complications occur in ordinary and conservative treatment. Using straight wire technique, it means it consists of simple leveling. So non-occlusal plane inclination control, occlusal interference, it keeps compression in the TMJ area and does not allow mandible adapters, blocked the mandible adaptation. And they cannot reduce the pressure in this region. It's my opinion because I put this from different papers on the one picture. I agree. And silence. So, decided that we need the fundamentally different tool. So it was, I was so afraid because she is my surgeon. So the gold standard is open treatment. So the previous treatment so aggravate the situation. So steep occlusal plane, anterior guidance more than 90 degrees, so very narrow and absence of first premolars, no retrogen control, and so on. It was a difficult decision, but I have no chance because my father, my teacher, Professor Slavicek and Professor Zaba, and I started to think, and it was my dream. I started to thought what I want to do for my patients. First of all, I want to open the incisors, open wide. It was first step. No, first step was healing. You're right, Professor Raj. The first step was to heal. It was very important. But during the treatment, I decided to open the bite to provide the mandible adapt forward and to make the compression in TMG area. And first of all, it was important to formate a very nice arch, upper dental arch fold. So, but very important question is, where is it possible to heal tissue and restore the function without anatomical integrity of the TMG? So this was a question for me very difficult. Is it possible? Daniela, where you are? She's it's a question also for you. Yes, because we just discussed another cases before my lecture, my presentations, and I think Daniela is experienced in this field of dentistry. That's great. Hello. Hello. So you agree? Possible to heal tissues because the surgeons doesn't believe.
Yes, it is.
So, but we know in our VieSID, in our school, after the classes, master classes, professors we know that this possibility exists, and we can compensate this patient. Okay, the treatment plan. First of all, change the system of the mandible fixation to the bracket system because you see the very terrible wires, emergency wires. Time for healing. Sure, and then we can extract the wisdom tooth from the lower jaw and open the bite to allow mandible forward the adaptation and unload the TMG. Occlusal plate flattening, occlusal support in new position of the mandible and restore retrosuve control of the mandible because we have not the first premolars. It was the problem. So it's only the scheme to move the teeth to compensate the open bite to plus open bite. So we start. I changed the emergency wires to their braces. This is very simple wires, only formatted in the mouth. So it's stainless steel. Only for fixation, because the surgeons was against, they hate our devices, and I decided to put these wires, keep tight all teeth for the time for healing. So this is September 2016. So it was after the 1 month of healing. The situation with soft tissues stabilized. You can see the hygiene is getting better. So, and in December, we start the active movement of the teeth, and I try to open the incisors on the upper jaw, because I have now to put the mandible in the therapeutic position because it's crazy incisors. Doesn't allow me to adapt the mandible. So, and step by step, I tried to open the incisors and put. At that time, I put the lower jaw still like reference stable position, but it was a struggle. I tried to open, from month to month. So, and I remember every time I asked my professor how to measure the activation, how many grams, how many millimeters I have to activate. And Professor Sada always say, just a little. Just a little, and I start to be more brave. So I decided to I prepare more severe activation. So, and you can see in February, it was interesting that we stopped to use remedies analgesic after the two activation. So, and pain is gone, their sleep problem is gone. So it was nice. And she believed me, so it was very important. So I tried to organize their nice upper dental arch. You can see it's getting more around. So, and at this stage, I use two multi-loop with tip back bend upper and tip back bend lower to create the open bite on the bark segment, to put together the incisors to close the bite. So this is our progressions. And I decided in spring, I decided to stabilize the upper form and try to do the crazy tip bend, because it was difficult to promote the rotation on the mandible. So I tried not only flattening the occlusal plane, because it was very important to promote the rotation, because can you remember the self on the red zone? So this was spring in April. And now, Miguel, I know that we have a wonderful wax, and we can prepare the occlusograms and prepare the activation using the occlusogram. But at that time, I need in articulator. So I fixed the models almost at every appointment. So because I was worried, and I tried to check every appointment. So. Yes, it's special case, but you can see that the sedation changing. So, and you can see that changing the form of upper jaw and lower jaw, and you can see no contact on the molars, but on the right side minimum, on the left side not that. So I check the position of the mandible skeletal changing. So it's the first day we fixed the braces. This is in April, and you can see the start. You can see the difference between the right side and the left side. I was worried a little bit, so I tried to rotate the mandible and try to prepare some steps in the premolars, but it was difficult, and I spent a lot of time. I think now, if I start to use this technique, this approach of treatment in patients, it takes maybe one year, I think. But at that time, I have no chance. It's approximately 2. So, and I try to check the situation in TMG. It was amazing that all little pieces tried to put together at the native place, you know? You can see later the several CT. So it was amazing, because I cannot understand what's happening. Maybe this is, maybe they disappeared inside the capsule, so maybe something else. but they all try to put together on the top, on the bottom of their condyle. So, and finally, I decided to prepare the condylography. So no condyle, no problem. But I decided to do the condylography because it's, for me it was very interesting and very useful to understand what's happening in the TMG. So, it's the first time in my life I presented the condylography without condyles. So look at this picture. You can see that this is protrusion, right side, left side. Sagittal condyle inclination 13, imagine, and 31 on the left side. So it's crazy chasing, I know, but I can't describe it because it looks like very severe arthrosis. So. But reproducible. So, what do you think? What do you think is going in the joint? Daniela, help me please once more. So maybe somebody describe, maybe some thoughts. So, what's happening inside? I don't know. Maybe a resorption of the condyle. Broken condyle, broken pieces, resorption broken pieces maybe, so, and where is this disc? We don't know. So Anastasia, maybe one suggestion? Okay, do you have idea?
Natasha. No resorption. At the same time, you have resorption and reposition.
Reposition.
So at the same time. There's no resorption first. It's together.
I was at resorption, but there is no happening, you see.
No, it will grow and later on resorb. But if you could have an MRI, you'd see the discs are on top of the broken piece.
Mm-hmm.
You need that resorption first, and then through the periosteum, the muscles come and make a new one.
I doubt the disc was on the bottom because dysfunction on the right side. Maybe disc was shifted on the bottom.
You have three ligaments holding the disc to the condyle. When it fractures, it goes together with the piece. If you have an MRI, we could see that.
Okay, thank you very much. So, and you can see that at that time, in the start we have a severe class 2, and now we have class 2 tends to 1. We are the winner, so it's good news because I think it's very important to see the skeletal compensation, and then we want to see the compensations. Sure. So it's before it's start, and this is the during the treatment. It's not end, it's during the treatment. And you can see here, severe class 2 goes to class 2 with tendency to 1. Inclination upper incisor is strongly diminished, and you see the incisor is normal, open. The protrusion of lower incisors, protrusion is increased. This was my problem also because in previously orthodontic treatment, the inclination was very increased and so difficult to put together the upper and lower dental arches. And you see in the next picture, we see the one blue, so on the red, and we see the blue one. Point. So let's go ahead. I decided, okay, by going ahead, we try to put together, and you can see that she is still dolichofacial, very severe dolichofacial type, but there is no problem, no pain, no muscles problem, and you can see the very nice upper jaw, round upper jaw. And articulate next fixation, next try to fix the intermediate results. So, and I cannot change more the incisors of the lower jaw. It was the problem. So, but you see the open bite on the right and left side. So it means we rotate the mandible and we help for build adaptation, forward adaptation of the mandible. At that time, I tried to dental art to not increase, to getting better the interdental arch relations. You see the activations. And you can see some appointments in September, November, December. Sometimes incisors open, sometimes closing. So it was a battle also near the incisors. So the next progression you see. And in March, I decided to check once more in the CT, and you can see the almost healing. It's almost fixed this part of condyles. Condyles looks not nice, but working. And at that time, I decided that my problem was absence of good retrusion control. Always I try to put the mandible forward, but cannot to fix it on the stable position. So I decided, you see the anterior guidance changing, and I decided to prepare the retrusion zone, wax up the retrusion zone to put the mandible to the more stable position. Where is my waxing? Okay, it's progression. Oh, here. So look at this 26 October 2018. So occlusal plane getting better, you see, and the scale, we can use the scale, but not previously before the treatment, and TOP is 18. So, and I decided, I remember suggestions of Professor Sata, and I decided to prepare artificially because I cannot chance to adapt and fix without any interventions. So I prepare the wax up and some silicone key, and you can see in the this is retrusion control. I use these insertions, but I think now that there is a steeper. Maybe now I decided to use maybe 45, I think. Professor Sade, what do you think about it? Because very steep, I think. I'm afraid because my patient was without condyle. It was a very dangerous situation. But now I think I prefer 45. So you can see these places in the mouth. So and it was nice for me and for patients, and the jaw stabilized, and we can check the form, arch form. You can see the progression from start to end point, not end point, until now. And you can see in December, after approximately 2 years, not 2 years, maybe 1 and 7 months, I think, we spent for the treatment. So you can see a very nice lady, very happy, and you can see the result. But it's very important for me because I think wherever you know that you can do whatever you want in your specialty, let's wait please. Something new is arriving. So, because after 2 years, after the quiet and very nice life. There are new complaints. She come back to me and complains, 2 years I was happy, I was so enjoyed life, I was alright, but after 2 years start to complain, not pain, but soreness on the right side come back. So it was unpleasant for me, and I decided, okay, we come back. You see, very nice occlusion. So I decided, okay, I have to check. And you see they're not big, but erected the muscles. Erected the muscles, and I see the compressions L1 on the right side, come back on the right side. So, what can we do? Once more we check their bone situation, CT of the condyle. And I decided, okay, I fixed the model inside the articulator, but I have no, unfortunately, I have no port without the wax. My technicians fulfilled the upper molars because there is no tight contact between the molars, I found. I was surprised, but what do you do about this? 2 years. I remember that when you remove the braces, you have no estimate the long functional orthodontic result, because we need, like Professor Sapa says, compensation and weight and adaptation. So I think it's my opinion, that my patient adapt to the new position of the lower jaw, to the new occlusal plane, to the new anterior guidance. So and something changing in the bone, in the condyle, I think. So I decided it's more easy. I fulfilled, you see, the molars upper jaw. Why upper? Because the occlusal plane is still stiffer. So we need we need more stiffer occlusal plane. I decided to fulfill the upper molars. So good occlusion, and so it's only for you. I decided to invite you before my coming here. I decided to see what's happening now. This is 2 years later, so it was in 2020. So it's now. You see the nice lady, good form, and good occlusion, and very interesting for me was compare the occlusal plane and position of their casts in the mountain. You see occlusal plane, it's approximately 40. That's great. Well, that's great. It's nice, I think. So you can compare the first models with emergency wires, and second one it was in March. So interesting, changing the position and contour of upper and lower dental arches. So, and finally by the new CT, and you can compare what's happening in their jaw. I understand we fully compensated our patients only in the level of occlusion, I think. So I keep the mandible only by occlusion. What do you think about it? No? No? Because I don't know, look at this huge distance in the joint. So you see the destruction, you see the condyles, the process healing was completed, so not nice, but it works. So it's interesting, it's working because she is happy, and when the patient happy, we are happy also. You can see the self, its final self, and you can see now there. Something wrong. see that we changed the skeletally our patient. And you can see very interesting. Remember 13 getting 18, 35 on the left side. But until now, huge tracing, and I think it's like artificial pseudo articulations only. I don't know how named. I cannot describe a very interesting speech. Swallowing, relaxing. So it's self before and after. And my thoughts and conclusions. So finally, it was a big challenge for me. This is not the best my case, but I so appreciate because it's a big experience for me. I was so afraid previously when I see my colleague with this wonderful virus in mouse. So, but now I think it's very important to understand and collect the same cases to understand what is happening in their articulator. And first of all, I think close treatment of bilateral fractures of the mandible condyle in adults is possible. It's true. So, in literature, we found the complications complications after the conservative treatment. It deals with the straight wire technique. So when you use the control, the subtle philosophy, when we use the control occlusal plane, vertical dimension, position of the mandible, and anterior guidance, and all things. So now happening in the patient is happy. So. And we believe that it's highly recommended for big centers of maxillofacial trauma to have orthodontists in their teams. I think it's a very interesting message for our colleagues, I mean for surgeons. So here you see my patient is happy and she's still at my orthodontal office. I'm a patient in your chair. So, and she has very nice 2 dogs, and every time traveling from one country to another country because there is some competitions and so on, and she's happy. And I remember the friends yesterday told us that we changed not only the position of the mandible, not only the position of the teeth, we changed the life, quality of life. So. And Professor Slavic always touched my hand when I come here and ask me, tell me please about your educational center, tell me please about your dentists and about your problems and so on. And finally ask me, it works? It works? So, my answer, you are right, dear professor, at all this moment.
Thank you, Natalia, for this difficult case. Are there comments? Somebody wants?
So, my opinion, I think I'm really sorry to begin. I think if I saw the result, I think in the beginning I made the wrong decision to keep the condyle in this position because I missed your CD in the beginning. This is some total fraction. The condyles are already on the position. So I missed this part. I think if in the conservative to keep the healing, if they are partially fractured, not complete, and made this good. But if you see the result of the case, I think, I'm sorry, I made the wrong decision.
Thank you for...
I don't know I'm correct or not, because I think that finally, beautiful occlusion, beautiful approach, very good, really orthodontic orthodontic treatment, all the concepts we have learned is included inside. But finally, I was the one that just talked about the business here. We made a beautiful occlusion, but compensated with the morphology, the discus and the condyle. This unit is not here.
Yes,
I asked ourselves in that case, in 10 years later, 20 years later, this young age, what happened in the future, I don't know. This is why occlusions good, but this condyle and the viscous, we don't know what happened there. And the position of the structure not here. Function, she's not okay, but I don't know the future. If I see this result, I would like a beginning maybe better use top the surgery to bring the condyles back, reposition, to fix with needle and the rehabilitation there in the correct position, and then later on use splint and use orthodontic step field. Perhaps it would be better. I'm really sorry. This is a very difficult case, but we learn a lot. We learn really a lot in this case.
Thank you very much for your comment.
Thank you for presenting the case to us.
It's interesting.
And I'm sorry, I did not look at your
Okay, I have time. So Jan Esther presented us 2 years documentation. So I have time.
Yeah, Natalia.
Okay.
Great case, beautiful, a lot of work. My question is, I missed the beginning. My question is, how long did you wait from the time that the accident happened to get the patient to treatment?
I changed the wires on the next day. One day, she comes to office. It was one day, and we discussed with surgeons. We made decisions, so it was tough time. And then the second day, I changed the wires because hygiene was poor and periodontal problem was existed.
So right away?
Yes.
Okay,
yes.
thank you.
And I missed my vacation, so I canceled vacation. It was the first day of my vacation, and my partner called me, "Come back, please, because we have emergency situations, so we need you," and so on. So
We call it Murphy's Law. It always happens at the the worst time. The wrong time.
Thank you. Compliment for your presentation. Very nice. I think it is very difficult to record the injections in a condylography in this case. Which problem do you have?
For me, I was surprised. If you see the start, the axis right and left almost inside, very near. I think it will be all very far from the right or side, but no. Look at the first tracing. It's final. It doesn't work, I think. Okay, just a minute. The most difficult was to keep this appliance to the mandible. You know, there is no compression TMG, and I fixed the condyles. So first. works without me. So maybe here. Oh. Look at this. It was without condyles.
It's a miracle.
Interesting. So, Professor Sata, thank you very much for your wonderful tool, because it's for prosthodontists, for orthodontists, it's so amazing to use the wonderful approach. We start to manage very difficult cases. And this is I never done before. So thank you.
Congratulations. Your approach is very good. Still, I'm thinking this condyle, that the condyle head fracture. Therefore, adaptation on condyle remodeling, all these processes is slowly going on. Fracture, usually fracture, stimulate bone remodeling. Therefore, if you more unloading, then stimulate bone remodeling. Maybe this is possible. Yeah, just thinking. But anyway, the occlusion, I want to make a little more appropriate with the brain.
Yes, I sure. I know.
Yeah.
It was struggle. It was possible.
Therefore, just small idea, you made 2020, you did waxing, then all this retroceral control you made. Before that, also logically, I want to advance upper front more. Then make a gap. Yeah, mesial, distal. Tooth number 5 is anyway small. Therefore, I want to make a big tooth number 5. Yes. Maybe. But anyway, thank you very much.
Thank you, Natalia, for sharing the case with us. My second question was why you went for 20 degrees of little plane inclination when your SCI is that flat. Can you update us with some, let's say, Brooks checker from how this is fitting into that new dental frame? And this would be great to see if this steeple from the plane will function in the years 20.
That's good questions. At that time, it was a tough time with COVID. All was closed, so and we had no bags, no work shippers. It was some supplies problems. But now I think it's very interesting to have a progression. I start to check that every year. So maybe I will collect the new version of this clinical case, and we will see in another summer school. So I think it's you are right. It's very important to see.
Okay. And my first question is: in the beginning, you asked us what would you do, and there was a slight consent for unloading the joint, and we decided to start treatment immediately with feedback activation, and this is more compressive to the joint in my experience. And open question to everybody: if we would delay a little bit the orthodontic treatment, we could maybe introduce a new vector of force in terms of decompression vertically, not only vertical with a strong elastics with a strong medial or
healing on the start, you mean?
Yes, you started immediately.
Immediately over the
Only
lines.
joined by clip-back plans.
That's great. So I will be brave the second time because I am afraid that that time it was 2016. And
Sorry for being so clever in the backward view.
no, it's amazing. It's great, and I'm so happy. I hope that this is a discussion. So I bring the cases.
Anybody else?
Daniel, thank you. Are you expecting to have interferences in the posterior because of occlusal plane and sagittal condyle inclination?
I think now I support. I got the occlusion support for the joint, and I understand that it's very important to save the position. So I try to save this mandible a long time because imagine when the tooth, one tooth will be extracted. So and we need implants, so another kind of prosthetic reconstruction. So it will be difficult. So I understand that I fix the mandible under in space. It's only by occlusion reconstruction. So
What about disocclusion? What about disocclusion?
Disocclusion was about 0. So it's because imagine it was 18 on the right side. It's like balanced occlusion on the right side. We prepare artificial onlays on premolars and canines and compensate little canine domination. Because 0, no condyle, no problem.
Thank you.
So, first I like to say that in my younger career, I was involved in a lot of mandibular surgeries and open surgeries. I can honestly say, never, 90% of them never turned out well. There was an extreme number of complications, so I think your conservative approach was an honest attempt at trying to do the right thing for your patient. And even at the end of the day, if you look at the condylar and say, well, that wasn't successful, well, the TMJ patients that I operated on all had those condylographies 20 years later. Maybe a little looser, a little longer, but they all, none of them come out looking normal again. There's a definite trauma to open reductions or things. But having said that, with the comments that have been going around, I'm confused whether your concept was to compress the joint or cause compression or distraction, because your therapy initially in opening up or your mechanics to open up the intrude the posterior teeth causes a compression, and I think in a fracture like this, maybe we should have done a large distraction, not a compression, and that didn't happen with your mechanics. Your concept was good, but I don't know where in the mechanics we got that distraction that we need. And I'm not talking about a little bit of anterior elastic. I'm talking about a big distraction that's going to pull the fracture piece slightly over the top of the displaced fraction. What's the opinion of everybody? Yes. Initially for the healing phase, I think yes. And a distraction, not a decompression, but a distraction.
Okay, I understand. The first step for healing, you prepare the splint to fix the mandible to allow the.
I don't think I can control the fact that I'm going to get compression when I start early with the orthodontic therapy, and I think I
you have a social thinking. I'm orthodontist, I'm orthodontist thinking, I think. So thank you for your comments. It's interesting.
I need somebody with more experience on that.
That's great, thank you.
Okay, I think it was a very interesting discussion, and the interaction between the audience and the presenter was very good. So congratulations, Natalia.